we're gonna start. Today is diastolic function assessment. What are the techniques that are used to assess diastolic function? It's really echo and echo. You will hear from other speakers who are my dear friends. But truly, what you want is an assessment of cardiac structure and function. There is nothing that we do in isolation when we evaluate patients, or for that purpose, when you evaluate cardiac function. It's not that diastolic function is a story by itself. It's usually part of a disease. Could be a part of a hypertensive heart disease, diabetes, valvular disease, and so on. To sort of put things in perspective before we start so we understand what we are measuring and what are the goals of these measurements, let's just take a moment to talk about invasive assessment of diastolic function. This is the gold standard. This is where everything started. And so this is what we call a pressure volume loop. You have the pressure on the x-axis, the volume on the y-axis. And during diastole, once the mitral valve opens, there is filling of the left ventricle. You can see the volume increasing with very little increments in pressure. And then the mitral valve closes. The ventricular systolic pressure rises during the isovolumic contraction period. That culminates in a systolic pressure in the ventricle that exceeds the aorta. Aortic valve opens, ejection. And then at the end of ejection, pressure drops in the aorta in the ventricle compared to the aorta. The valve closes, aortic valve closes, and you have a drop in the ventricular pressure during the isovolumic relaxation phase. The word isovolumic means that the pressure is changing in these phases without an actual change in volume. We understand that there may be trace leaks of mitral regurg, of aortic regurg in normal individuals. That still does not change this terminology. On the other hand, if you're looking at significant mitral or aortic regurges that take place during these phases, they are no longer, so to speak, isovolumic. And so the diastolic pressure-volume relationship can be assessed by changes in pressure and how they compare to changes in volume. So we look at end-diastolic pressure-volume relationship. This could be done, or the proper way of doing it is by altering the venous return and thus altering the end-diastolic volume and end-diastolic pressure. And we look for this curvilinear relationship and characterize it mathematically. That's one aspect. Another aspect is to look at how fast this ventricular pressure is dropping during the isovolumic relaxation period. The actual Doppler methodology is based on looking at filling and motion, and then using filling and motion to draw inferences about diastolic function. So we're going sort of a step backward, so to speak, not a direct look at what is happening. And during early diastole, there is a left atrial pressure that exceeds the left ventricular pressure, opening the mitral valve, forward flow in early diastole with filling of the ventricle. We can look at how fast the ventricle fills here. Still, we are looking at filling, really, not looking at pressure. And with late diastole, the atrium contracts, and you're looking at the atrial contribution to LV filling. How fast the velocity rises, how fast the velocity decays, how quick the valve, mitral valve opens once the aortic valve is closed. These are all measurements that we look at and are the traditional measurements that were sort of looked at late 80s, early 90s to gain insight into diastolic function. The ventricle motion can be looked at, and we look at the annular motion. So in diastole, the annulus recoils away from the apex, and we get a small recoil during the isovolumic relaxation period, then during early diastole and during late diastole. With impaired relaxation, the ventricular pressure decays slower. And so in early diastole, you have a higher ventricular diastolic pressure, smaller gradient, and that's the inflow pattern you're all familiar with reduced early diastolic recoil, because now the atrium, when it contracts, it has more volume, priming it to contract, so it has its own Frank Starling. You get a more forceful atrial contraction, and that's the pattern that you see. If the heart is beating faster and we want to keep the ventricle filling, then we have to force more flow into the ventricle in early diastole, and the price that is paid here is the higher left atrial pressure. You can switch between these two patterns by giving someone a diuretics who's in heart failure. Conversely, if they are compensated, but they are not exerting discretion over their salt fluid intake, they can get into that pattern. Now, relaxation is a key component when one talks about diastolic function. How fast the relaxation takes place and also the extent to which the relaxation is complete determine the ventricular diastolic pressure. If you were to look at the two aspects of relaxation, how fast it takes place and how complete it takes place, how complete is the more important one. This is the one that determines equilibrium volumes that we may get to talk about briefly. So if a ventricle is relaxing slowly, but we are allowing enough time for the ventricular pressures to drop, then the ventricular pressures will drop enough to allow forward flow from the atrium into the ventricle. There are many ways of modeling ventricular relaxation. I will not get into these methodologies, but important to notice that to get to measure this data with high quality, you need a high time resolution, which comes with high fidelity catheters, not the regular fluid-filled transducers. The expression that is most frequently used is the assumption that the ventricular pressure drops in a mono-exponential manner, and the negative inverse of the slope is tau that one is interested in deriving. Also, a quick point about relaxation. Relaxation by itself is load dependent. The word load dependent becomes important because we use it a lot when we talk about indices of function, of diastolic function, and so on. Even if you measure the time constant invasively with high fidelity catheters and accurately, what this recording shows you that as the ventricular pressure increases, the ventricular systolic pressure increases, the time constant increases as well, and these are significant increases. So if my gold standard is dependent on load, it makes very good sense that all of the surrogates of this gold standard are also dependent on load. Another aspect that we touched on briefly on the pressure-volume loops was the end-diastolic pressure-volume relationship, and that is dependent on wall thickness and chamber geometry, and that's why it is important to look at LV structure, be it by echo, CMR, or other techniques. The pressure-volume relationship in diastole also depends on the passive material properties of the myocytes themselves, the sarcomeres, the proteins that make the sarcomeres, as well as changes that happen in them. We will not talk about that, and also the extracellular matrix. So this is fibrous tissue and so on, and hence the promise to look at replacement fibrosis and expanded ECV. If we want to express the relation between the two variables, pressure and volume, that's one of the expressions that can be used. There are many other expressions, but I chose the one that is most frequently and the easiest to deal with. If we go for a first order differential of this expression, we can see that the ratio of, or the rate of change in pressure to rate of change in volume is directly related to the pressure with a stiffness constant. This is the stiffness constant that is used to characterize chamber stiffness. And again, to get to that data, you need invasive measurements with high fidelity catheters, and you need to combine, as you see, pressure and volume as well. That's an example of pressure-volume loops that can be done invasively with catheters in the ventricle. We have work we're doing with our heart failure colleagues and transplant patients, and shows you a lot of data that can be obtained. Many of this data is invasive and it's systolic, but also several are diastolic. Dr. Prim is doing this research project, and we are hopeful we can gain new insights. So now we step back to the word, what is the definition of diastolic dysfunction? You can say it's a slow pressure decay. Notice that if you're trying to draw inferences based on filling rates, as you just saw, you can see patients with impaired relaxation and reduced early filling. You can also see patients with impaired relaxation but high left atrial pressure and therefore preserved early filling rates or even increased. We look at the diastolic pressure-volume relationships, and we look at steep relationships. That's what we refer to frequently as shift to the left. For any given volume, the pressure is higher. Clinically, what is done is people measure end-diastolic pressure and other pressures in the ventricle and the atrium, and you also look at filling patterns, but notice that these are inferences. Neither of them really goes directly to what is happening with these two functional parameters we talked about, rate of pressure decay and the pressure-volume relationship, except indirectly. This is taken from an animal model. A dog, normal dog, and a dog were pacing-induced heart failure, and we see in the upper panel very small pressure gradients between the ventricle and the atrium, but nevertheless enough to allow for filling. As heart failure sets in, the minimum pressure in the ventricle gets higher. Notice here it's low. Here is almost 10 millimeters mercury. In normal hearts, this is 0 and was shown in humans to be even less than 0 when you give them positive inotropic, lusotropic agents like catecholamines. There is a phase in mid-diastole where the pressures in the ventricle and atrium are very close. The end of that is the pre-A pressure. This pressure is called pre-A because it precedes the atrial contraction, and the pressure is very similar to the mean left atrial pressure and the mean wedge pressure. Then with atrial contraction, you get another pressure gradient. In the setting of heart failure, end-diastolic pressure increases, and you can see in this example it even exceeds the atrial pressure, which means there cannot be any forward flow from the atrium to the ventricle during this time. We've already touched on these velocities. And so now with that background, let us talk about Doppler assessment of diastolic function and filling pressure. The principles we touched on briefly in this summary slide here is assuming that you're looking at a heart that is not normal, but abnormal. But if you go to normal subjects, all of these indices are affected not only by the rate of decline of LV pressure, so to speak, but also by left atrial pressure. And so if I have two variables and both of them, or even three variables, and both of them or all of them are changing at the same time, it becomes challenging to isolate the effect of one of these parameters based on a given change, say in mitral inflow. To that effect, guidelines were published by the joint publication by the American Society of Echo and the European Association of Cardiovascular Imaging in 2016 towards the guidance of how to look at diastolic function and to estimate filling pressures. Because there are so many pressures that we talked about in this, as you saw in these slides, it's important to say what pressures we seek to estimate. Because the mean wedge pressure and the mean left atrial pressure, which is tied to the mean wedge pressure, and the pre-A pressure, all are the ones that determine whether someone has shortness of breath or not. The goal is to estimate these pressures, not the late diastolic ventricular pressures. So that's an important point to remember. Which pressure are you trying to estimate? The word LV filling pressure is quite sort of big, and there can be significant differences in some patients where you have a patient who has a high EDP but a normal mean pre-A pressure. There are specific patient populations also where general guidelines do not apply to them, and they are listed on this slide, quite a few. But that doesn't mean we cannot make reasonable assessments of diastolic function and filling pressures in these populations. They have special measurements, or certain measurements carry more weight when we try to assess diastolic function in these situations. We'll not delve into these because of time reasons. So when you are evaluating a patient, the first question you want to answer is there diastolic dysfunction, or is there a high likelihood of diastolic dysfunction? To get to this answer, you want to say, is there evidence of cardiac disease, be it structural or functional abnormalities? And here we want to look at the clinical data that is available. That's why sonographers and physicians should seek to look at this data. Not saying accept everything that comes across, but what is decently documented is something you should consider. Look for evidence of cardiovascular disease on the 2D findings. For example, someone with CAD and regional dysfunction, wall motion abnormalities, pathologic left ventricular hypertrophy as someone with aortic stenosis or hypertension, someone who has a history of hypertension and a big left atrium and there is no evidence of mitral valve disease. Left atrial enlargement here is an indicator of diastolic dysfunction. And the presence of systolic dysfunction. Systolic dysfunction by itself is usually associated with diastolic dysfunction. And the cascade of events of ischemia, diastolic dysfunction typically precedes systolic dysfunction. And as we were talking earlier, when you evaluate cardiac function, it's not any element of cardiac function that is looked at by itself in isolation. Everything is in the context of the whole study. And so it's important to look at systolic function, not just EF, but also long axis function, as with global strain and mitral annular descent indices, be it the absolute descent or the S prime velocity. Some people question whether left ventricular hypertrophy by itself is a good indicator that there is indeed diastolic dysfunction. After all, this is something that tells you the wall is thick. Why is that muscle then having relaxation problems? So there are ways of answering that question. One way is to look at Doppler velocities and see them abnormal when someone has diastolic, when someone has LVH. The caveat to this approach is, as we were talking, Doppler indices, velocities included, of course, are affected not just by one variable, but other variables. A more reliable way is to look at these measurements invasively. So if you seek the literature and do a search, very few studies have looked at invasive indices as the gold standard in patients with LVH. Let's first agree what are the invasive criteria for abnormal diastolic function based on generally accepted European criteria, which have been revised and re-revised since these publications. A time constant of LV relaxation that exceeds 44 milliseconds and an EDP that exceeds 16 millimeters mercury have been taken as major indicators of diastolic dysfunction. And so this hypothesis was tested in 63 patients who were given a diagnosis of heart failure and an echocardiogram that showed LV hypertrophy and normal ejection fraction. Invasive indices were the gold standard here. And what we're interested in is not Doppler, but to see how many of those patients with LVH had an abnormal tau as assessed invasively by Millar catheters. As you notice, 79% of these patients had a prolonged time constant and 92% had an elevated LV EDP. So it's a reasonable assumption. We talked about strain as an indicator of systolic function. I believe you've had lectures about strain and its assessment. Again, strain is never looked at in isolation. You have to see the quality of the signals, blood pressure, and heart rate. Also, some Doppler signals have special importance that one should look at. These include pulmonary veins, positive Valsalva maneuver, different inflow patterns for the left and right ventricles, and the L wave. People have looked at the guidelines and tried to summarize them and come up with few measurements, but really these are key measurements that should still be looked for and assessed. That's an example from a patient with heart failure preserved EF. There is the mitral inflow, there are the pulmonary vein velocities, and you notice a very prominent atrial velocity in late diastole. If you remember the dog with pacing-induced heart failure and the very large LV EDP that exceeded atrial pressures, in this situation, which is very similar to HFpEF, forward flow in late diastole is minimal, and most of the flow that happens with atrial contraction is now backward into the vein. So an atrial reversal velocity that is at least 30 centimeters per second with a prolonged duration compared to mitral inflow is a good, solid indicator of increased EDP and diastolic dysfunction. The peak velocity and the duration of that atrial reversal is not age-dependent. As someone ages, provided they have normal diastolic function, this velocity doesn't change its amplitude or duration. Hence the importance of recording pulmonary veins in all cases, and the feasibility in ambulatory patients should easily be in excess of 85%. An example also of a signal that is useful is with Valsalva in someone who has a pseudonormal, what we call pseudonormal. It looks normal, but the reason it looks normal mitral inflow is because their left atrial pressure is up. They increase their intrathoracic pressure, venous return drops, LA pressure drops, transmitral gradient drops, and now you have that inflow pattern. If you have a patient who is able to cooperate and follow instructions, important to do a Valsalva as opposed to not doing it. Examples of a patient with a cardiomyopathy here, and you have high fidelity catheters in the left ventricle and the right ventricle. Notice all diastolic pressures in the left ventricle are increased, whereas pressures in the right ventricle are normal. They are mirrored nicely by the mitral and the tricuspid inflow. This tells you that mean RAP is normal, and that tells you that LAP is up. That's why it is also important to get tricuspid inflow. We put a sample volume at the tips of the tricuspid valves, and you want to record a number of cardiac cycles or at end expiration, so we are able to look at this information. This is an L velocity, and what is happening in mid-diastole is because of ongoing LV relaxation, because relaxation is slow. LV diastolic pressure is still dropping, but LA pressure is up, and you're having a velocity in excess of 50 centimeters per second. That tells you three things, or the usual scenario to see this finding is increased LAP, impaired LV relaxation, and slower heart rates. It can also be recorded in the annular velocities, as you see in this example. So now if we've seen the whole study and everything looks normal, these signals are not there for us or they are normal, what do we do? Before jumping and saying someone has diastolic dysfunction, we want to look at several variables: annular velocities, E to E prime ratio, average septal and lateral, peak TR velocity, which we should acquire from multiple windows, and biplane LA volume. Important to record correct LA volumes, which means we may foreshorten the left ventricle by going one higher intercostal space to get the correct LA volume instead of the same view that gives us the maximum LV size. As you can see, it's an important variable for diastolic dysfunction, but I would also submit it's an important variable that you want to measure correctly in all patients, be it patients with heart failure, with arrhythmias, with mitral valve disease, and so on. If the majority of the signals fall outside these ranges, then the patient has diastolic dysfunction and usually elevated LAP, because many of them foretell you that the LAP is up. If they fall in the normal range, it's normal, and in between, it's indeterminate. The yield of indeterminate, if you take everything into account, should be of the order of at most 10 to 15%. So what happens if we have three variables and we don't have four variables? Then you look at what the three variables are telling you, and if the majority of them tell you LAP is up, then LAP is up. If the opposite, then LAP is normal. So now if the conclusion is reached that diastolic dysfunction is present, irrespective of how you arrived at that conclusion, then the next step is to say what the LAP is and then grade diastolic function. And that's the algorithm that is used. It starts with the mitral inflow, and then if the patient has a value 2 or above, that puts them already in grade 3. If it is 0.8 or less with an E that is not exceeding 50 centimeters per second, then they have a normal LAP, and in between you want to look at these other variables. The guidelines have a footnote that you should look at pulmonary veins with systolic dysfunction and look at S to D ratio. What happens if we see someone who is symptomatic, short of breath, but now they have a normal LAP? They can have diastolic dysfunction, and it is important to consider a diastolic stress test for these patients and state it as such in the report. As you know, invasively, when a patient who presents with shortness of breath, possible heart failure, preserved EF is seen, who has a normal wedge pressure at rest, they can proceed and do a stress test in the cath lab to look at what happens to their pressures with activity. Of course, limited stress tests, usually supine bike. An important take-home message is do not stop at these four variables that we just showed you, but look at everything else, including pulmonary veins, what happens to the inflow pattern with Valsalva, look at mitral tricuspid inflow and L-wave velocity. And the stress test is strongly acknowledged in the guidelines because some patients can have normal pressure at rest, their pressure increases with exercise along with shortness of breath, and that could be helpful. But if you have someone who's short of breath, whose LAP is already elevated, there is no reason, as you would thing to proceed to a diastolic stress test. Important in the diastolic stress test, not only to acquire mitral and annular velocity, but also TR. Why? Studies have shown that E to E prime ratio with exercise has a good sensitivity, but lower specificity. Specificity improves if you get the TR jet. By the same token, TR jet by itself should not be equal if increased to diastolic dysfunction, because some patients can have pulmonary hypertension due to pulmonary vascular disease where their PA pressures increase with exercise, and it is not a story of group 2, say, pulmonary hypertension or HFpEF. Example for a positive diastolic stress test is shown here. The annular velocities are reduced at baseline, E to E prime ratio 10, peak TR 2.6. With activity, E stays low, the ratio goes up, now 95. You can even recognize an L wave, and the peak TR is 3.5, corresponding to an RVRA gradient of at least 49 millimeters mercury. So we'll see some cases, and if you guys have access to JACC imaging, I don't know if this is available for many of you or not. This whole issue of January is an issue dedicated for diastolic function, has several state-of-the-art reviews, and also features several cases that you can go through. These are narrated cases that you may enjoy. We'll take you through several applications of diastolic dysfunction. Dr. Chamsi-Pasha and Dr. Shah have a nice article in this issue. Just go through it and hope you enjoy it. Okay, let's look at cases here. This is someone, an older woman, presented with shortness of breath. Apparently, not clear history of hypertension. And when we look at the mitral inflow, it's a ratio less than 1, so this fits an impaired relaxation pattern. However, if you look at the annular velocities, the E prime is reduced, the atrium looks big, TR is incomplete. So let us sort of summarize. EF was normal. A ratio of 0.8 to 0.9, peak E more than 50, an average E to E prime ratio of 15, an LA maximum volume index that is enlarged, and the TR jet is incomplete. So we go and say which algorithm we apply. We're not presented with anything else. There was no GLS provided to us or S prime, but we can say that E to E prime ratio was increased, the E prime velocity was reduced, TR was incomplete, but LA was big. So 3 out of 4 signals were available, and all of them are concordant. So we will call diastolic dysfunction. Then we say, let us estimate wedge pressure. We are in this middle category, and 2 of the 3 available signals are concordant. So that puts us at grade 2 diastolic dysfunction. Cath confirmed this finding, and you have very nice pressure recordings here. Sometimes when people are doing right heart cath, they push the catheter all the way out, it gets hit against the wall, and you end up with a damped PA pressure that gets misread as wedge pressure. One clue you are in the wedge position are obviously the pressure waveforms, fluoroscopy, and ideally you want to see an oxygen step up in the blood that you get. There is an A with an X descent, there is a V with a Y descent, and the mean pressure is pretty high here, as you see, between 25 to 30. Example from someone with depressed EF is shown here. You have a restrictive inflow, very minute annular velocities, very large left atrium, and a TR velocity that is clearly more than 3.5. So that's a quick summary. Notice it didn't take us any time to look at these signals that were nicely acquired. And that puts the patient into E to A ratio of at least 2 and grade 3 diastolic dysfunction. And the pressure confirms these findings. Again, decent waveforms and a high wedge pressure. Since their publication, there have been several studies looking at the accuracy. I'm using a study that we were the core lab for. Here included 450 patients. Accuracy very decent compared to clinical accuracy, and here clinical was judged by clinical exam as well as chest x-ray and natriuretic peptides as evaluated by cardiologists, not internists. Significant difference, and when you look at subgroups, groups that are particularly challenging, obese, patients with pulmonary disease, very decent accuracy. Not perfect, but acceptable and certainly useful clinically. We also looked at the agreement between different observers. This included a large number of observers. Some were members who wrote the guidelines, some were labs outside the guidelines, some included experienced echocardiographers, some included echocardiographers with less experience. And you see here, based on the Kappa statistics, very excellent agreement, irrespective of the experience level of the observer. Also, since its publication, several labs have tried to look at how these guidelines affect their flow and their yield. Notice that the number from this particular group from Canada, number of studies that could not be accurately classified when the guidelines were, or adequately classified when the guidelines were published, dropped from 79% to 2.7%, and the reporting of diastolic function improved to 89% after the update. And that was their conclusion. This is work in progress by this particular lab in abstract form, but hopefully will be published soon as a full-length manuscript. Also, several publications have looked at the guidelines and their ability to predict outcome. This is from a post-MI population from an Australian group, looking at the impact of diastolic function as assessed by guidelines over clinical parameters in LVEF. Patients refer to a heart failure clinic, and you see very good outcomes for patients who are classified as normal versus those who are classified with diastolic dysfunction. Indeterminate group fared in between. This is from a population with multiple sclerosis, so primary systemic sclerosis, where pulmonary hypertension due to pulmonary vascular disease plays a big role. Outcome events were worse in patients with diastolic dysfunction that was stood on multiple variable analysis. There are other indices that have been looked at, including isovolumic relaxation rate as measured by strain, as well as in early diastole. This shows you that this signal during isovolumic relaxation relates inversely with the time constant and directly with negative dPdt in animals. Also did well in humans and was incremental in predicting outcome in a population presenting with acute MI. LA strain also is gaining interest in the echo world. You can look at the reservoir strain here in different segments, could be done by tissue Doppler or was done by tissue Doppler early on, now speckle tracking, and was shown to relate inversely to wedge pressure. Which particular group of patients this signals will be most useful in remains to be determined. So in conclusion, if you want to look at diastolic function, and you should, and you apply the guidelines, look at clinical findings, look at all 2D findings, look at all the signals that you get from pulmonary veins, mitral and flow, annular velocity, strain. If you have a patient who is symptomatic and the findings are stopping with a normal pressure, you should proceed to a diastolic stress test. If after that evaluation you are still not able to arrive at a definitive conclusion of what is causing dyspnea, then certainly cardiac cath. Thank you.
Well, good afternoon, everyone. I would assume since there is a role for MRI in heart failure with preserved ejection fraction, Dr. Nagueh was the guest editor for that special issue in JACC Imaging, and he invited us in the MRI lab to contribute to that issue. So I had the pleasure to work with Dr. Shah on getting a review about the role of CMR in helping to assess and evaluate patients with heart failure with preserved ejection fraction. So really what we're going to be talking about is what can MRI provide in terms of data. So you can actually get geometric data like LV mass and hypertrophy. You can also look at strain data for the LV and or the LA. And more importantly, there is a growing need for assessing the extracellular matrix, which as we know is the whole premise of diastolic heart failure, which is increased myocardial stiffness. So we have techniques like T1 mapping and ECV mapping to assess that. You can also look at the morphological changes in those patients with long-standing HFpEF, like assessing LA volume. You can also get transmitral flow velocities, and finally, myocardial tagging. So to start up with, MRI is really kind of a non-invasive, high-resolution imaging modality, which really gives you an unrestricted field of view where you can get morphological changes, functional parameters, chamber volumes, and perfusion all in one setting. And at the same time, what is unique, it's the only tool that provides data at the myocardial tissue level because it non-invasively can assess for scar, both replacement fibrosis, as we can see with late gadolinium enhancement, but also interstitial fibrosis, which happens at the microscopic level, and that's where T1 mapping and ECV helps. And really kind of MRI can also provide a lot of data about LVH and left atrial volume. So the way we do LV mass on MRI, we're not restricted by any geometry. We acquire contiguous short axis images through the entire LV. We have a fixed slice distance. And if we see here on this image, we can trace the epicardium contour along with the endocardial contour. And then the LV mass is basically going to be this volume between the epicardium and the endocardium multiplied by the specific gravity of the heart. When we move to flow velocities, which we have been using in MRI for a long period of time, you actually have another non-invasive, non-contrast need to basically measure flow, velocities, and volume through any region of interest. So just to kind of one slide about the mechanism of doing that, if we look at stationary tissue, so protons that do not spin at rest, there is no change in their phase, but whenever they are subjected to an external gradient magnetic field, we do realize that moving subjects, they acquire different phases or different shifts in their phases during different velocities, and that's what we're able to image with an MRI. So you acquire this data, which we call the phase image, where you'll see here is the central aorta, and you see here is the pulmonary artery, and you're able to assess volume based on the area of the region of interest multiplied by the pixel velocities, and that's how we get volume. So similar to echo, whenever we're looking at the inflow parameters on Doppler, you're looking at the E wave, which is the early diastolic transmitral velocity, and the A wave. So creating a perpendicular axis to cross through this mitral inflow, you're able to obtain those velocities, bearing in mind that this is not at the same temporal resolution as echo, so your velocities on MRI could be underestimated. One of the other reasons why this also has not been widely implemented, because we all know that the mitral annulus has a very dynamic motion. If the imaging plane is not perpendicular, you can underestimate the velocities, and you also have some signal loss in people with concomitant regurgitation along with lower temporal resolution. Now, LV strain, as we know, the definition of a strain is the change in length after it is being subjected to pressure. So that's what we call the deformation of the heart. So it is the delta change in length between diastole and systole divided by the original end-diastolic length. And we all know from echo, from the cardio-oncology, and from other literature in cardiomyopathy that strain really adds a strong diagnostic and prognostic marker for LV function. So over the past few years, we've had an emerging technology on CMR where we're able to use this feature tracking, by which what it does, you actually have a post-processing software that's able to track those voxels inside the myocardium, and it's tracking the motion of these voxels over time. So with that, you're actually able to assess the displacement changes, and with that, you're actually able to get both longitudinal strain, which basically you're looking, as we all know, there are three types of strain. We have the longitudinal, which is the base to apex descent. We have the radial strain, which contributes to your ejection fraction, along with the circumferential strain. So you're actually able to estimate and get a bullseye view of the longitudinal and the circumferential strain using this post-processing feature tracking with MRI. And at the same time, you actually can get and acquire a whole three-dimensional heart with a heat map in order to demonstrate longitudinal strain at different segments of the myocardium. Now, the one thing that really MRI really stands out is the ability to non-invasively get an accurate assessment of replacement and interstitial fibrosis. And as we all know, the holy grail of diastolic dysfunction and heart failure with preserved ejection fraction is increased myocardial stiffness, which leads to impaired relaxation. So we do now more and more literature, we all know that the excessive extracellular matrix, it seems to be a major contributor to stiffness of the myocardium. So there is this unique times that we acquired during the MRI examination. One of them is the T1 time, which is how long does it take for the myocardium after being subjected to a magnetic field to relax and get back to its normal relaxation phase. And we do have seen multiple studies showing abnormal T1 values in people with HCM and amyloidosis along with diabetic cardiomyopathy. And anything that increases collagen tissue or expands on your extracellular matrix is going to prolong your T1 time. So here's a T1 map image that we can see. Here's a short axis view of the heart. So here's the LV, here's the RV, and we are at the mid ventricle. And if you look at this native T1 time, 925 milliseconds appears to be within normal for this case. Well, if you look at this patient where you can see here, it's a diastolic image, there's significant increase in wall thickness, and the T1 time of this myocardium is extremely prolonged, meaning that there is it's taking a longer time for the heart to recover, which basically the premise of the impaired relaxation that we see on echocardiography. The other technique is the extracellular volume, which is basically looking at the change in contrast in the blood or the T1 time in the blood and in the myocardium before and after administering gadolinium. And here you can see a case where an ECV map was normal at 24%. And here you see a case where you can see there is a large increase in the extracellular volume or extracellular matrix that's been expanded, and you have a markedly elevated ECV up to 39%. Different literatures have used different cutoffs, but it sounds like the upper limits of normal is anywhere between 29 to 30% for ECV. This is a recent paper published in JACC Imaging looking at the relationship between myocardial fibrosis and CMR, both focal and diffuse, and outcomes in patients with heart failure with preserved ejection fractions. So they had 96 HFpEF and 44 controls, and they were able to demonstrate focal fibrosis in almost 50% of patients with heart failure and preserved ejection fraction. Almost 75% of these were non-ischemic, meaning that they were not related to CAD, and the diffuse myocardial fibrosis or extracellular volume was higher by 25%. So the indexed ECV, which is ECV divided by which is indexed to the myocardial volume or the LV volume, was 13.7 versus 10.9, and they had a total of 42 composite events in this group. So this is some pictures from the MRI. So here you're looking at the late gadolinium enhancement. So anything that is black is viable, and anything that is white is areas that have gadolinium uptake. And you can see this focal fibrosis at the RV insertion point. Here's a software that can quantify the scar that is being seen. Here's another focal fibrosis that appears to be more in the mid-myocardium / RV insertion point. And then here's another fibrotic change that seems to be in the mid-inferolateral wall. So what they were able to demonstrate on the Kaplan-Meier curves is that these people who've had higher quartiles of indexed ECV, this was a major predictor for mortality along with repeat hospitalizations for heart failure. Now, the other thing that also MRI can provide is accurate data about left atrial volume. We all know from the CT and the MRI literature that LA volume is significantly larger in those cross-sectional imaging modalities than an echo. And the normal reference values of upper limits of normal is 53 ml per meter square for men versus 52 ml per meter square for women. The way we do LA volume on CMR is exactly the same way as we do with an echo. So we have a 4-chamber view where you see the left ventricle, the right ventricle, and we acquire the area and the length on a 4-chamber along with the area and the length on a orthogonal view, which is a 2-chamber view, and we are able to use the same equation to derive a biplane left atrial volume. Here in this case, patient has a volume of 198, which is clearly severe for this patient. Here's a paper from Dr. Shah's group here where they were looking at the LA volume indexed by CMR and its association with mortality. And this was for people who were coming in for a clinically indicated CMR examination. They've demonstrated that up to 52, these people basically have a essentially very near normal expectancy and very low event rate, which here they were looking at all-cause mortality. And then as the left atrial volume increased by 10 ml per meter squared, these people start to have an increase in their hazard ratio. And really the people who have the most severe left atrial enlargement, which is defined as an LA volume index of more than 73, these people have had almost a double the event rate for all-cause mortality based on this paper. The same thing from echo, you can also use strain derived from MRI. And with that, because you have a dynamic imaging both in systole and diastole, you're able to assess all the 3 functions of the left atrium that we know about. So it's the reservoir, it is the conduit along with the pumping or the atrial contraction. And these basically curves can be plotted with volume on the y-axis and time on the x-axis. So we can see the reservoir, the conduit, and then the active pumping function. And basically from the MESA cohort, which included a lot of cardiac MRI, based on this paper from a few years ago, both the left atrial volume and left atrial function, they were independent predictors for people to develop subsequent heart failure. And the ones that were stood out in a multivariable analysis was a larger left atrial maximal volume, but also a larger left atrial minimal volume and a preatrial contraction volume. Now, where also MRI really adds in the workup of people who have a heart failure with preserved ejection fraction, but we're not able to assess whether or not there are any other reversible causes for this patient to have diastolic dysfunction. So especially if you have someone with unexplained severe left atrial enlargement and they do not have major risk factors like hypertension or diabetes, you really want to try to think outside the box. Could there be an alternative explanation causing their HFpEF? So here you see an asymmetrical septal hypertrophy on this three-chamber view. So this is a case of hypertrophic cardiomyopathy. And here's the scar image for this case. And you can see quite extensive patchy non-coronary artery disease scar in the septum, also consistent with HCM. And here's another case where a patient has significantly increased pericardium thickness that almost approaches 4 to 5 millimeter. And you can see here on the late gadolinium enhancement, very high signal uptake from gadolinium, suggesting active inflammation in the setting of constrictive pericarditis, both of which can be phenocopies of diastolic dysfunction or HFpEF, but these are reversible causes that you have treatments for. Here's a very nice study that was published in JCMR over a year ago, where they took 154 patients with HFpEF, and they all underwent simultaneous transthoracic echo and MRI with both stress and rest perfusion. So they were doing a ischemic stress testing, and then they were also doing scar imaging. And CMR detected disease in 42 patients, almost 27%. Now, there is referral bias in this study because it was a single center study, and these people who they screened a lot, only 154 of them ended up. But the diseases that were detected on CMR is occult CAD, so this is where you see the replacement fibrosis on CMR, microvascular dysfunction, which was detected on stress, myocardial imaging with perfusion, HCM, and constrictive pericarditis. And what they found in this study was that a new CMR diagnosis was the strongest independent predictor of outcome, which here was a major adverse cardiac event, including hospitalization for heart failure, all-cause mortality, with a hazard ratio of almost 1.9 and a significant p-value, and there is worse outcomes noted on a 6-month follow-up, including death and hospitalization due to heart failure. So this is a sample from their paper where you can see here is a subendocardial scar in the circumflex territory in a patient who has occult CAD. Here's a patient on stress perfusion imaging has an inducible ischemia in the RCA territory. And here's a patient on stress CMR who has a global subendocardial perfusion defect suggestive of microvascular dysfunction. Here's a case of asymmetrical hypertrophy consistent with HCM. And here's a case of thickened pericardium with intense pericardial inflammation suggestive of constrictive pericarditis. So my final take-home message is MRI, you're never going to send a patient for MRI to kind of assess what their diastolic function is or calculate their filling pressures. This is what echo is born to, and very pleased to talk after Dr. Nagueh, who's been the maestro of diastology. But really, MRI is to answer a question, am I confident that if I have someone with unexplained left atrial enlargement and they're relatively young, am I missing some other alternative diagnosis, which can happen in young people, like HCM versus constriction, along with other novel markers in CMR that seems to be emerging so rapidly is the T1 mapping and the ECV mapping, which is the holy grail of myocardial impaired relaxation, whether or not these people, we can catch them at an early time and hopefully intervene before they develop significant symptoms. Thank you so much for your attention, and happy to answer any questions. So everyone have an excellent relaxation time. So everyone should